So, good afternoon, everybody. Welcome once again to our series of webinars run by the Royal Society of Medicine by health professionals for health professionals. So we've got in the habit now once a month of going back over what we've discussed in the last month. And indeed, just looking back over how the series has been going, we've actually had over 2,000 people watching each of our webinars. YouTube recordings of them have been viewed over 30,000 times. We've had viewers from over 90 countries all around the world. You filled in 6,000 feedback forms, God help you, and you submitted over 2,000 questions, 600 of them in the last 4 weeks. And so today we have a team together to answer all those 600 questions that we haven't managed to get through in the last 4 weeks. So speak quickly, team, when I come to you. So we're bringing together, first of all, or we're bringing back Professor Stuart Ralston, rheumatologist, clinical trialist, editor of Davidson's Principles and Practice of Medicine that somehow got me through medical school, surprise to everyone, and chair of the Commission on Human Medicines. Martin McKee, epidemiologist extraordinaire, chair of European Public Health at the London School of Tropical Medicine, and Alison Pittard, who's also been on our programs already, consultant in intensive care medicine from Leeds, Dean of the Faculty of Intensive Care Medicine. So, but I thought first of all, we're going to have a little bit of a new feature that we haven't had before, and this is going to be our desert island paper. So we'll ask each of you individually to name what you think has been the most significant paper, advanced or discovery in the last 4 weeks you would like to take with you to your desert island or Barnard Castle, whichever is the nearest to you. So, Stuart, would you like to kick off with your desert island paper for this month?
Thank you, Sir Simon. What a thought. Yeah, I mean, I think by quite a long way, the paper in the New England Journal describing the results, the preliminary results of the ACT study was the one for me. So that was the randomized placebo-controlled trial of remdesivir in COVID. They enrolled about 1,000 patients. They were using an ordinal scale of severity to assess if the drug was working. And actually the DMC, the Data Monitoring Board, stopped the study early because of quite compelling evidence of efficacy of remdesivir. The duration, the primary endpoint was improved by 25% by the treatment, and also mortality, although not significantly different, was actually also about 25% down with remdesivir. So very encouraging results with this drug, and we hope to see further data. But that's my desert island paper. Thank you.
But just before you, that's brilliant. You did it in less than a minute. But surely it's another of these things. Had they kept it going a bit longer, might we have actually had a significant effect on mortality? Because now we still don't really know. We're not sure. Can we do another trial of this?
Good point. I mean, there are other trials ongoing, but actually, what there still is going to be information coming out of that study. I think about half of the patients in the study had reached the end point, at which point the DMC said, you need to tell people about this because there is evidence of efficacy. So follow-up is ongoing, and I think we will get information as the data matures, and hopefully it will be the same as when the trial was revealed, or at least the results of the trial were revealed.
They kept the randomization going, did they?
Yeah.
Oh, I see. I didn't know that. Oh, okay. Well, that answers my question. Okay. So, Alison, your desert island paper?
Yeah, well, I've decided to move away from COVID and try and get back to some semblance of normality.
Wow.
I know, exactly, bit extreme. But I've chosen a paper from the Journal of Intensive Care, which related to sepsis. Because of course, before COVID came along, sepsis was the big thing, and we need to get back to it. And this was looking at antimicrobial administration and the time that patients receive it when they have suspected sepsis. And it was asking, is faster better? Looking at administration either at 1 hour or 3 hours. And actually what that paper, they were using propensity scoring, and it didn't actually show any difference. And before all this, the faculty was leading a collaborative on sepsis on behalf of the academy, because the actual evidence behind giving antibiotics early is very, very, it's not very sound, and therefore we need to look at other things, because is it the time from when you first suspect it, when it's first diagnosed? So we need a much more comprehensive approach to sepsis and its treatment, and consider early detection, multiple interventions and goals beyond simple time to antimicrobials. And I think that's going to have a big impact on sepsis going forward.
Because sepsis isn't going to go away when this is all over, is it?
No, absolutely.
It's very reassuring that you are looking to a future and we don't have to talk about COVID, I must say. Okay. Martin, your Desert Island paper.
Oh dear, well, I'm going to bring you back to COVID.
Oh no.
In fact, I would have had the New England Journal trial as one of mine, but I expected that somebody else would do. I actually would have liked to have had two that are completely different. One, which was from the CRIC, which was about the predictors of an adverse outcome. But the one I'm going to go for is from the BMJ, and it's from Piccinini and colleagues in Lombardy. And it's the use of all-cause mortality to quantify the consequences of COVID-19. And what's interesting about it is it's a population-based study looking at all-cause excess mortality during the course of the COVID pandemic. And it showed that in the month of March, the excess mortality was between 10 and 12 times higher than it had been at other times of the year. And I think what this is pointing us towards is the challenge of working out the complex consequences of this disease, because we are now, I think, recognizing there's so many problems with the reported data on the number of deaths that are reported at the press conferences every day in the UK, which clearly are out of line with the excess mortality being reported by the Office of National Statistics weekly. And we need to try and find out what's going on in that gap. Many of them undoubtedly are COVID deaths that are not being attributed to it. But there are other things that are going on, and this is one of the pointers to that. But it's something that we're all struggling with in public health to know what is really happening there.
So I'll allow you a little bit longer to it. So explain again this difference that we're getting between the ONS and the other data, and explain which should we be paying the most attention to.
I think we should be looking at the ONS data.
I thought you'd say that.
We've just done an analysis across Europe of the different definitions that are being used. The Financial Times, which is probably the best source of international comparative data, Chris Giles and his colleagues have been reporting all-cause excess mortality for a number of countries and regions within countries. And clearly the COVID pandemic is causing those deaths. Now, whether it's the COVID virus is causing all of those deaths or it's the consequences of the lockdown and so on, that's the real challenge that we're struggling to understand. But if we look at the UK in general, we're picking up about half of the total excess mortality in the daily deaths, whereas other countries like Belgium, for example, the headline numbers they report account for over 90% of the overall excess mortality.
Okay, so we'll be coming back to some of those comparisons. It was a thing that we neglected a little bit when we had you on last time, so we'll come back to that. And I think I'm allowed to select one here. I was going to select Ben Goldacre's BMJ paper, the Open Safely paper, which linked the electronic records to 17 million adult patients, something most of us have spent our life not being able to do. And Ben, who was my trainee for a while, has obviously gone on to far greater things. And it's not so much this paper, which looks at risk factors for mortality from COVID. It's more the promise of what that system can now deliver, hopefully for all of us, that I think is, I'm trying not to use the word game changer because it's one of those cliches one should avoid, but I have just failed to avoid it. But it certainly, I think, changes the game. Do you think that's a fair point, Martin? It's in your world?
No, I do. But the challenge is actually untangling all of the risk factors that are there. There are issues around, particularly when you look at things like the risk to people in Black, Asian, minority ethnic populations, risk factors, trying to untangle all of that is really very challenging. So I think the paper is great, but it raises an awful lot of questions as well. Well,
that's fair enough. And we will come back to the BAME issues as well. But as I say, we often talk about the power of the primary care records that we have linked to our hospital, and yet we've never really been able to do that until now. Okay, so let's go work through some of the questions that have piled up and that we didn't pick on. I picked out, there's at least 20 or 30 questions on ACE inhibitors, ACE2 inhibitors from all sorts of different shapes and forms of questions. But perhaps for Stuart and Alison, first of all, lots of people just wanting to have some explanation and explore the issue of them as therapeutic agents in treating COVID-19. Where do you think we are with that?
Well, I start. I think, I mean...
Yeah, sorry, Stuart, you get off then.
Yeah, thanks. Obviously, the virus enters the cell via ACE2, and then there's been lots of theories. Well, ACE inhibitors might make that go up, it might make that go down, it might block it, it might do this or might do that. And we've gone from this was the most terrible thing you could do to this is protective. The data as it is suggests that being on an ACE inhibitor, or for that matter an ARB, it really does not influence, it certainly doesn't make COVID worse or make severity worse. One interesting thing that came out, I'm sure you saw it, I'm sure everyone saw it, in the Lancet paper, the big Lancet paper on hydroxychloroquine, which has,
yes.
which I'm sure we'll come to. They looked at a lot of things that might influence outcome. And one of the things that struck me on their forest plot was ACE inhibitors seemingly were very protective. And it has been, obviously this is an observational study, you've got to take into account the caveats, but you know, ACE inhibitors do protect the vascular system, and one wonders whether, if anything, it might be beneficial. I certainly think it's not detrimental. Okay, Alison?
Yeah, no, I agree with that, but I think one of the things that we don't know is what the wider role of the ACE receptor is, because if you start looking at that and looking at how they're expressed in different people in terms of, you know, children having higher levels, and then the older you get, the levels going down. But it doesn't seem to make sense. It contradicts what, you know, other things. And the more I read, the more confused that I get. And I think it's actually very, very complex. And there's obviously something going on beyond the receptor. And we know there are genetic and phenotypical differences between people. So I think it's going to be absolutely fascinating going forward to try and get all this unraveled. And who knows where it's going to end and whether we'll get any answers.
It is
okay. Well, one question clearly hasn't quite got the message, because one of the questions we got is, do children have less ACE inhibitor, less ACE2? And I think you just said they have more, haven't you?
Yeah, well, I mean, again, different things that you read say different things. But the last thing I read was that children have more ACE2 receptors, but
okay.
that there are membrane bound and there are circulating receptors as well. And so it might be down to the balance of one against the other, as to if you have more sort of soluble circulating receptor, then that allows the virus tends to bind to that rather than to membranes and then passing into the lungs or whatever to cause infection. So that might be one of the reasons why children may not have any symptoms, because it hasn't entered the cells via membrane bound receptors, but it's circulating, so they're carriers and able to pass the virus on.
Okay,
there are also gender differences as well, which may add to the complication. We were, I mean, this is obviously not my field, but I was struggling to try to understand it, like I think everybody else. And my impression was that there is a difference between not a difference between the actual receptors, but in the lung and in the vascular system, in the way that they respond and all of the other things that go with that in this infection. So I think what we're seeing is particularly the effect of ACE inhibitors as potentially protective on the vascular system. There is a paper just out in the Lancet suggesting that there's no difference in the probability of being infected in people who are taking them or not taking them. But there are several observational studies now suggesting that those people who are taking ACE inhibitors do actually rather better.
Well, that's you've also dealt with two of the other ACE questions, and I'll have one more left. Which says that is it now safe? Is it now okay still to use ACE inhibitors for hypertension when a patient is affected by COVID?
I would say yes, definitely.
Yeah, so would I.
Okay, so fortunately there we do have a firm conclusion. The rest does seem to be more research is needed. Okay, fair enough. Now then, Martin, and one that we got a huge amounts of feedback because we never got your opinion on, but now it's time to talk Sweden. Okay, so are they reckless or are they a beacon for the future?
Well, the rationale behind what they did was a belief that ultimately they could not keep the virus out and it would get in anyway, and you would have to move to a position of herd immunity. That does not seem to be the case, and they've now experienced...
Which doesn't seem to be the case, Martin?
Well, it doesn't seem to be the case. What seems to be happening is they've been sustaining a very high death rate, like the UK, very high death rate, particularly in care homes. But the death rate is now much, much higher than it is in the other Nordic countries. Now, the question is that as we move forward, and with the benefit of hindsight a year later, how much difference will there be? And clearly, I don't know, and nobody else knows at the present time. But I have to say, on the balance of the evidence, I would say that they've been reckless. That
was clear. And yet their cousins in Norway, I'm hearing that their senior epidemiologist is saying we should have followed Sweden more closely. That seems slightly strange. This is where we get into this tension between the balance of the harm caused by the infections and the harm caused by the restrictions. But there's a very large death rate now. Obviously, the populations of Denmark and of Norway and Sweden are different. Sweden's a much larger country, but we're still talking about 4,500 deaths in Sweden if we take the official figures, compared to just about 240 in Norway, and that's a very big gap. And also we need to remember that even in Sweden, even though there were minimal restrictions, there were some on large gatherings. Data from Citymapper and from other sources shows that very early on, people were restricting their movement. They were social distancing to some extent as well. But like us, they've had a particular problem in care homes. I think to quite a considerable extent, their ex-prime minister said, being Swedish means you already have a gene for social distancing. That has been said, but I wouldn't like to lapse into national stereotypes, as some of my best friends are Swedish. Well, he was their prime minister. Okay, so you're clearly on the reckless side, but you do also agree that as you said before, it is perhaps also too early to come to some of these judgments. And anyone else want to come in on that? I mean, it's been widely debated. It's one of the most asked questions we've had. Okay. Well, still on the international comparison, the other country we didn't discuss, and again, much discussed, just slightly south, is Germany. And again, first of all, Martin, do you want to, some of the things from Germany is a little contradictory as well. So do you want to sum up, first of all, what's your understanding of what actually has happened in Germany? And then we can, all of us, I think, discuss what are the reasons, because they're probably complicated. They're certainly complicated. I think it is complicated. Yeah. Germany introduced restrictions at a relatively early phase, and also it has had a very extensive testing program. People were able to go to pharmacies and get test results back very quickly. So I think that's been able to control outbreaks. There have been a number of outbreaks in southern Germany associated with festivals, for example, but they were able to move in quickly and respond to that. And I think what we've seen internationally is speed really mattered. There is a graph in the Financial Times showing when the lockdowns occurred relative to the early cases, and it's almost a linear relationship, admittedly on a log scale. So I think moving in quickly, having a very effective testing program, and having a devolved public health system that was able to respond really quite effectively, that was what made the difference. And once it gets out of control, as in a number of other countries, then you really do have problems. Okay. Alison, they also have much higher levels of intensive care beds. Is that true?
Yeah, they do. I was going to bring that up. So, I mean, every healthcare system is different, and also the patients that end up in hospital and have a certain type of treatment is very variable between countries. But when we look at critical care capacity, Germany has one of the highest levels of provision in Europe. So they have around 29 critical care beds per 100,000 population. And we in the UK, and I've forgotten the exact figure, but it's around 6 or 7.
It's lower, isn't it?
South Korea has about 11. There's only a handful of countries that have less provision than we do. So, of course, Germany wouldn't have been anywhere near as concerned as we were about the ability of the critical care services to cope. And I suppose that air of not panicking and knowing that whatever happens, you're going to be able to deal with it, means that you can look at things in a much more pragmatic way. Whereas if you're thinking, how are we going to deal with this, and you're rushing around trying to create capacity. It's almost a knee-jerk response. So it's you know, it's very, very different situations.
But the truth is, we did end up creating capacity, didn't we, on a extraordinary way?
Well, it's very interesting because all the way through this, you know, the line has been, we have lots of critical care capacity, the NHS is coping, but the critical care capacity that we had wasn't providing the sort of care that we would normally do in non-pandemic situations. So we moved from a situation where we had one-to-one nurse-patient management to, at some points, at maximum surge, we were talking at 6 patients to one critical care nurse. Now, that is completely different. What we're trying to do, or what everyone was trying to do, is make sure that we could treat all patients, but they wouldn't necessarily get the same sort of care that they would under normal situations. And so it's really important that we pull back and utilise and re-implement the evidence-based standards that we use.
Now, you're clearly thinking again, as you were with your choice of paper, what happens after this. So you're making the case that when this is over, we shouldn't go back to having 6, 7 beds per 100,000. I think it was that. We should move closer to Germany. Is that, I assume that's what you're suggesting?
Well, I think actually that the Germany levels are probably sort of over the top for our healthcare system, and there's no doubt for years we have been trying to make a case for further investment to increase our beds. So in 2000 we had a massive financial investment, but over the last 10 years we've seen no increase in critical care capacity, but yet on year we've had a 4% increase in demand. So what we need to do is we need to learn from what we've experienced during COVID. And one of the things that we have experienced is that we need to make sure that when patients are ready to leave intensive care, that they do so, but still receive the right level of care. And quite a lot of time that isn't on a ward. They need to have this sort of interim. And patients we know beforehand fell into a gap where they might not have got into critical care and had to stay on a ward, but they should have been in this sort of interim level, which we're now calling enhanced care. So what we would like to see in the critical care community is looking and re-evaluating delivery of critical care services, and perhaps not just having more of the same, having some of the same, but then having something new where it's a much more efficient use of resource. And also in these enhanced care settings, all the staff, all the non-critical care staff that have come in, been redeployed, been cross-skilled, is that they could maintain those skills by caring for patients in enhanced care areas. And it would also mean that they would retain those skills and be able to redeploy back into critical care if we had another pandemic or, you know, some major incident. So to me, that's a win-win for staff, the NHS, and for patients.
Now, by some mysterious piece of thought reading, one of our questioners from Middlesbrough asked about the a forthcoming review on level of care between critical care and the ward. Now, I'm not sure. I think that is what you were just talking about there, isn't it? I don't work in general, so I'm not entirely sure.
Yes, so there's 2 pieces of work. Well, there's one piece of work going on and one publication. So the Faculty of Intensive Care Medicine, the Intensive Care Society are reviewing the levels of care, because we've had the descriptors of levels of care for a long time, well over 10 years. And so they may not still be fit for purpose. But the faculty, along with the 3 Royal Colleges of Physicians, published a guidance document only a few weeks ago on the development of enhanced care in the acute hospital setting. And this covers surgical patients, medical patients, obstetric patients as well, so that patients who don't necessarily quite meet the criteria to need critical care, but need a slightly higher level of monitoring or interventions that can't be delivered on a ward, can have sort of an enhanced service, so they get the care that they need by the right people at the right time. There's been a lot of interest in this. And one of the examples that demonstrates how useful it would be is in the elective surgery pathway. So we hear all the time that operations are cancelled due to lack of critical care beds. And often it's because the patients don't necessarily need critical care, but they need an enhanced level of care, which they can't get on a ward. And we don't have very many enhanced care areas at the moment. So if rather than trying to increase the number of critical care beds, which are expensive, if we put that money into developing enhanced care, so you probably get 2 enhanced care beds to 1 critical care bed, then you can be able to support a significant increase in operations so that patients don't get cancelled.
Okay, still slightly in Germany as we were. Stuart, again, you obviously have a view of you keep an eye on other healthcare systems. Do you think there are any other things in the German healthcare system that serve them to their advantage in the crisis?
I mean, I can't really add much to what's already been said. Martin has alluded to the fact they were on the lockdown very quickly. Now they have this localized test and trace system, and we've heard about the intensive care beds. Although I don't think that was the rate limiting factor. I mean, I don't think that was the influential factor. So, but fundamentally, I think other aspects of healthcare are probably similar. I'm not an expert in this area, Germany and the UK, but yeah, nothing much to add on that.
Okay, I mean they do have a not entirely dissimilar primary care system. One of the things closer to us than some other countries. So I still think in the interchange on Twitter a couple of days ago, Martin, referring to one of your colleagues, Carl Friston, who's a very famous neuroscientist, actually a psychiatrist. People forget that, but he is. He's the second highest cited neuroscientist in the world, brightest guy I've ever met. He started talking about the kind of went kind of all Philip Pullman on us and talking about one of the differences might be in the dark matter of immunology between Germany and Britain. And I have to say, I didn't really understand that. What was he meaning by that?
Well, yes, I think Carl is amazing, but I think perhaps that got lost in translation. I mean, this is a discussion a number of us have been having, whereby there is a sort of concept that with a new virus, 100% of the population are susceptible, equally susceptible. And that doesn't seem to be the case. There are parts of the world in Africa and elsewhere where it's not spreading as much as you might think. And even in the places where you might, in Europe, we're getting still relatively low levels of antibodies in the population of people who've been infected. So something needs to explain that. But what he meant by dark matter was that dark matter is something that you cannot observe in the universe, but it is necessary to explain the way in which the universe works. So it's simply things that cannot be seen but need to be there to explain the factors that are there. Now, I'm not going to get into the modeling that he's done because I know there are some questions, some issues around that. But what we're talking about here are a combination of factors which include perhaps a degree of cross immunity to some degree with people who've been infected by other coronaviruses, a degree of lower susceptibility. Perhaps the role of non-antibody related immune mechanisms, natural killer cells and other things. Perhaps some variation in ACE2 receptors and other receptors, because there are receptors on the lymphocytes in particular. You get an acute lymphopenia with this infection. There may be some variations there. So some of those that heterogeneity of receptors, and then a whole lot of issues around heterogeneity of transmission in the population, because not all of us meet the same number of people, interact with the same number of people all the time. There are some people who will stay at home on a Saturday night, watch television, not have any contact. Other people who will go out to the pub and will meet 100 people or in the nightclub. And when you try to factor in that heterogeneity, the K number that's been talked about a little bit there, then a combination of all of these factors need to be there in some way to explain some elements of the models that are being seen. But it's dark matter only, not in a mysterious way, and I think maybe the terminology did not help. It just means that there needs to be something else going on there, which is probably a combination of all of these factors: heterogeneity of exposure, differences in other forms of immunity. So, for example, there is evidence from Africa in particular that people who have helminth infections may have a general immune stimulus as well, which may be protective against virus. There's some evidence of that. So a whole series of things like that that are coming together that just might be, maybe you could have said, well, unexplained variation or something like that, but he was using an analogy with physics.
Okay, fair enough. Not all of us are capable of understanding Carl all the time, but it's always worth the effort.
Actually, Simon, just on that, it made me, just hearing Martin speak, it was reminiscent of the famous Donald Rumsfeld, the known unknowns.
Yeah. Just thinking that. Just thinking that.
But we've got the contribution of all of these things. You know, we are realizing this is a very, the pathology of this virus is very, very complicated.
Yeah. That will be a pub quiz question for the future. What do Carl Friston and Donald Rumsfeld have in common? Okay. I don't think so. But anyway, okay, now then, also coming up a lot, probably back to you here, Stuart, is a lot of questions were asked about thrombosis, coagulation, and so on. Do you want to update us a little bit on where we are with that in terms of trade? Well, straightforward question, for example, should we be anticoagulating severe COVID? Or is early heparinization advisable now?
Yeah,
so
well,
just give us the updates.
Okay, so it's become clear that thrombotic complications are, quite common in this condition. It's quite complicated though, because people are immobilized, they're in hospital, and of course, just on general medical wards, if you're admitted with COVID or with not COVID, you're given mini-hep or low molecular weight heparin. So I can't see there ever being a trial, not giving people low molecular weight heparin if they're in that situation, because I'm pretty sure everyone is getting it. So I would say in ill people or seriously ill people, it's probably part of standard care. Seems to make sense in reducing probably the risk of thromboembolic disease, but I think that's where we're at. I would view it as a kind of supportive care, really, rather than maybe a definitive treatment, but who knows?
And Alison, do we have any idea why the risk of thrombosis does seem to be higher? Everyone seems to say the same. Do you have any idea why?
I don't think we're entirely clear at the moment, but one of the possible explanations would be damage to the epithelium done by the virus and the whole inflammatory response that occurs because of COVID. And once you get damage to the epithelium, then you get exposure and platelet adhesion, and platelets get activated, etc. So I think it's all part of the immune response to this disease, and beyond that, we don't really know at the moment. But that's sort of appeared as we've seen patients with microthrombi in the lungs, and that's the underlying cause of the severe hypoxemia that we've seen clinically with patients.
And from my colleagues at Toyota, seem to be a much higher rate of strokes as well. And the neuropsychiatric consequences of that. Is that a fair observation?
Yeah, that's certainly what we're seeing, and also we know that that COVID does have neurological impact as well, because it can get into the brain via the same receptors.
Yeah, we had Ed Bullmore talking very fluently on that last Tuesday. So again, if you want to have a quick explanation of that, go back to the recording we had a couple of
I think there also is a role of the interleukin-6 and tissue factor and various other, the cytokines in particular, in stimulating thrombin generation. So there may be an increasing tendency to coagulopathy in the blood. But I think the endothelial function is going to turn out to be really quite crucial in all of this. And I'm sure that I suspect in the end, we'll find in the whole sort of armory of drugs, some of the ones that stabilize the endothelium may well be playing a role, as well as those that have an impact on the
Martin, I wonder if there's anything you don't know. I've yet to find it.
I hang around with clever people.
Okay, fair enough. And I hang around with you. So on that, Martin, there was a thing that, again, in the 2 or 3 weeks since we had you on the webinar, we've learned more about the population dynamics now of mild illness and indeed asymptomatic illness, which was still obscure and is now starting to get more clear. Does this change, the estimate? Well, it should change the estimates we have of the lethality, the mortality associated with COVID. Now we're aware of a greater grip on the number of asymptomatic cases that have been out there.
Well, obviously there were a lot of models circulating at the early time, and some of them actually do seem to have been quite prescient. And I think the latest figure I saw, and the difficulty for anybody working in this area is it's a little bit like being on the receiving end of an artillery barrage of papers. I saw that Science did a review and found that in 1 week in April, I think it was, there were 4,000 papers published in 1 week. But the last estimate I saw was about 0.6 of a case fatality rate of under 1% anyway. So I think there have been a wide range of estimates, but we're settling into that sort of level. But obviously it's hugely dependent on the age distribution in the population and all of the other factors. Yeah, okay. But it is, as you say, settling into a clearer and tighter view. Okay, then a couple of other ones to I think these might be fairly straightforward, but because I followed you on Twitter, Stuart, but several people asking about vitamin D. Is this still a vitamin looking for an indication or not? Well, yeah, there is osteomalacia. It's a very good treatment for that. I think, I mean, naturally, the question about vitamin D has been raised. Older people are more susceptible, they have more, or at least they have a poorer outcome. People in the BAME group have a poorer outcome. Vitamin D deficiency is prevalent in those groups. It could be reverse causation. In other words, it's not anything to do with the severity. There is actually a trial I was very interested to see ongoing in France, looking at vitamin D supplementation. And I think it will be interesting to look to see what that shows. It's quite high dose vitamin D actually versus low dose. My gut feeling is it probably isn't playing a significant role, but we know that vitamin D does have effects in the immune system, especially in severely deficient people. So who knows? But I suspect probably it's not the magic bullet for COVID, I would say. Okay, and until this came along, you are, of course, an expert in metabolic bone disease, so you do know what you're talking about. Well, a little bit with regard to bones. Yeah, a little bit, yeah, okay. And another one someone's asked about, and this could be for everyone, there was a thing going around that maybe smoking was actually protective against COVID. Is that, I mean, it seems implausible, but is that still on the table or has that been nailed? Well, there is work by Anna Gilmore and her colleagues at Bath looking at the conflicts of interest in some of those papers. And obviously with anything with tobacco, we immediately look at that because that seems to usually be the main determinant of what a paper finds. Okay. Anyone else want to add anything to that, or you'll be suitably skeptical? Well, I did read a paper on that. And you know, like any of these papers, you can kind of concoct a theory about how nicotine and nicotine receptors might be involved, but I have to say I wasn't all that convinced. And I don't think, well, Martin will know better, the epidemiology has shown anything major on that, but it's not my area, so okay. I defer to Martin. Well, we do know that nicotine does not have a particularly beneficial effect on endothelial function. There's a lot of evidence there, and so, yeah. Okay, so we're moving towards the end now. We have added an extra minutes to catch up with all the work that we've missed, but I thought we'd go, you know, towards a discussion of lockdown in Europe and issues like that. So the Independent, Martin quoted you 24 hours ago, and the head, I mean, of course, a very good paper, why should they not? And the headline was, "Lockdown has turned into a trade-off between lives and people's livelihoods." And of course, you know, health has always been a trade-off. we all agree that there's both a health crisis and an economic crisis. And even before COVID, we were always making economic judgments about healthcare. That's why we have NICE, Stuart, as you would agree, to do things like that. But across Europe, Martin, it's clear that health has been the biggest concern in many countries, but that is now changing. It remains in the UK the highest concern, clearly by a very long country mile. But that's not the case in every country. So Italy, for example, the economy now has risen to well above health and people's concerns. Belgium, a bit similar to us. Greece, far very different, as you would expect. It's more, Martin, just tell us, how are we, given that we are making trade-offs all the time, we've never stopped, how are we going to do this in the future as it becomes clear that this isn't just a health crisis? Well, I don't think any crisis is ever just health of the economy. They're intimately linked, and they always have been. I don't think that it's an either or. You know, we need to control the disease. We need to control the pandemic. And what we see from the historical data, Chris Meisner and other colleagues in the United States have looked back at what happened with the lockdowns in 1918, 1919, and shown that those cities, and the individual cities were deciding when to lockdown, that lockdown earliest and remained lockdown for longest recovered faster. So by 1924, they were the ones that were doing better. The key issue here is, of course, the pandemic is having an impact, the lockdown is having an impact on the economy, but there are things that can be done, and the British government is doing a lot with the furlough scheme and with loans to small businesses and so on. And this is exactly what we saw during the global financial crisis. You know, clearly an economic crisis is bad for health, and you have rising levels of suicides and so on. And in many countries, the fall in, you know, the increase in job loss and the increase in suicides, as you know, go hand in hand, but not everywhere. And so, as we showed in a paper in The Lancet some years ago in Scandinavia, you could actually break that association by investing in what we call active labour market programmes, which essentially is the government saying, we care about you, we want to help you, we want to help you with retraining to get back into work, and so on. So I think during a period of lockdown, that clearly is having an adverse impact on people's health through loneliness and isolation, and really worrying for children. But it doesn't mean that then we should just say, well, that's going to happen, we need to get out of it quickly. We need to do all the things that prevent those impacts happening. If people do have to be locked down to control the virus, then what we need to think about is, how can we put in place support mechanisms to mitigate the adverse consequences of that? And I don't think we've thought anything like enough about that. In other European countries, what we see is, particularly because of the role of local government, if you were in France, for example, or in Germany, and you wanted the social services and all the various community services, they weren't working, you would go to the mayor, and the mayor would sort it out. Well, here, who do you go to? You go online to an outsourcing company contracted by central government. You hang on for hours on the phone. You don't know who to talk to. And I think that's one of the problems. We've been much, much poorer at putting in place all of those support mechanisms to help people who are suffering from the restrictions.
Okay, very, very well expressed. Anyone else like to add anything on these, how we do these trade-offs? Stuart, you work in policy.
Well, not really. I can't add anything to the very eloquent exposition that Martin has just given. And I think the local dimension, I'm very interested to hear that. I think the local dimension is very important. And I've heard that all the way along with this, that you know, maybe power has been taken away from local public health organizations, and maybe that isn't a good thing.
I think we've seen this very much with the programme for children on free school meals, with where the government put in place a system to make sure that the schools would get food for them. And you've had accounts of teachers head teachers getting up at 2 o'clock in the morning to log on to a system, and they find they're already in a queue of 300 people. You find they're hanging on the telephone forever. Whereas, as I say, in many other European countries, you would go to somebody locally and you would simply walk to their office door, you would knock on the door, and then somebody would be there who would have the ability to sort it out. We've lost all of that. And in fact, in some parts of the country, you know, we talk about easy councils where they've really pulled back from almost everything that they did and contracted things out. Or in the case of some of them, they're acting really as car parking companies and very little else.
Okay, beautifully put. So we need to wrap up at this point. One of the nice things from the 6,000 bits of feedback that we've had is people constantly say, I wish it had gone on for longer. This one has deliberately gone on for longer, but I'm also sure we'll get feedback said, no, even longer, because all of you are just warming up to the theme, but all of you, I'm sure, will be back. Thank you very much for helping out and for contributing to such an interesting discussion. Now then, we'll be back in 48 hours for the COVID series, and the next guest is Margaret McCartney. Many of you will know, a frontline, as we have to say these days, for everything, frontline general practitioner, much read commentator in the BMJ, an expert on evidence, and it turns out Nicola Sturgeon's favorite commentator. So she'll be here Thursday, 12:30. In between, a change of pace. Tomorrow, our weekly In Conversation in the evening that reaches new heights, with Roger interviewing Sheffield's most famous son, No, that's not me. I am from Sheffield. It's actually Sir Michael Palin. So that's tomorrow, it's written 7 a.m. actually, but it's actually 7 p.m. Pour yourself a glass, sit down, and I'm sure you'll be extremely well entertained. So then, as we say, Sergeant Phil Esterhouse at the end of every episode of Hill Street Blues, stay careful out there. Thank you very much. Good afternoon.
Thank you.
Bye.
Thank you.
Thank you.